And now we are going to be doing Parkinson. Yeah, you have any doubts in that?
No.
Okay, okay. So Parkinson's drugs are very easy. So basically, Parkinson's patients don't have dopamine. So we have to give dopamine in all kind of possibilities that we basically can. Okay, so for example, either give it as a precursor, which is a levodopa. Either give a drug that's going to increase the release of dopamine, which is your basically your non-ergot and ergot, that is your pramipexole, ropinol. Okay, so now otherwise you can also go ahead with the dopamine availability increasing drugs. Okay, so that's basically different. That means like for example you have the levodopa or you are having the dopamine which is broken down into something. Okay, like for example dopamine, the decarboxylation is basically prevented by the carbidopa. Okay, the conversion to your 3-O-methyl-dopa is stopped by your entacapone, tolcapone. So these are like increasing the availability of the dopamine. Even your amantadine, your carbidopa increases the availability because it's a decarboxylase inhibitor. Okay, because usually the peripheral conversion of your levodopa, okay, to your dopamine by the dopa decarboxylase, this decarboxylase enzyme inhibitor is your carbidopa. Okay, the levodopa to your 3-O-methyl dopa, which is going to be inhibited, okay, by your entacapone, tolcapone. So these are dopamine increasing availability drugs. So the next one is preventing the dopamine breakdown. So that's going to be your, so if you can see over here, selegiline, rasagiline, okay, these are going to stop the conversion of your dopamine to become your dopac. So in all of these case scenarios, except for your drugs which is antimuscarinic or anticholinergic, which is used only for your tremor and not your bradykinesia, except for that, all the other drugs are literally focused only on increasing your dopamine availability or the drug that is mimicking your dopamine or the drug that is inhibiting your excess cholinergic activity. Okay, so now in this whole case scenario, I told you the whole mechanism of action in one line because that's all is the mechanism of action. Okay, so now what we are supposed to understand is what is levodopa. Can you guys tell me what is levodopa? It's basically synthetic form of L-dopa. So what is L-dopa? Precursor to your dopamine. Okay, so why don't we give dopamine directly? Why are we giving levodopa? It's because dopamine cannot cross your blood-brain barrier, but your levodopa, it can cross your blood-brain barrier. So that's why we give L-dopa in the form of levodopa. Okay, so now why are we giving carbidopa? Because we don't want the conversion that back to dopa so that the dopa can't enter the blood-brain barrier and it doesn't go and cause the effect that it needs to do. Okay, so that's why the carbidopa levodopa is a very deadly combination that you have to remember. But what are the adverse effects of levodopa carbidopa? The most important is on and off period. Okay, like for examples, Parkinson's patients basically have tremors. Okay, Parkinson's patients basically have any motor related or extrapyramidal related movement problems. So you're giving the drug, they're getting better, but you're taking off the drug, they're becoming worse. Okay, so there's on and off kind of case scenario. Apart from the nausea, apart from the vomiting, apart from the, okay, so let's talk about the adverse effects one by one. Yes, they do have GI problems, nausea, vomiting. So now my next question is, why do you think they have hallucinations? Anybody? All these illegal drugs, okay, that you're basically doing, basically has an increase in dope. You have all these people who are on drugs keeping on telling you that they see something, the hallucinations. It's all because of dopamine. Okay, so hallucinations is because of dopaminergic neurons in the mesolimbic pathway. Okay, so now you should remember that this is not a adverse effect for levodopa carbidopa. It is just an adverse effect for dopamine. Anything that is increasing dopamine. Okay, so now the next is dyskinesias, which is what is your on and off period. Okay, the dyskinesias is basically like a side effect to your levodopa. So now the next important is orthostatic hypotension. So this is one of the side effects that's going to persist irrespective of you giving or adding on a carbidopa. Okay, so that's why whenever we give carbidopa or levodopa to like elderly patients, we always think twice, okay, because it's very dangerous. Okay, so because when we are giving carbidopa levodopa, there is decreased formation of catecholamines in the periphery. Can you guys tell me why, when I give carbidopa levodopa, there is decreased formation of catecholamines in the periphery? What is the precursor for your norepinephrine and epinephrine? Dopamine, right? So now you guys have to remember in your carbidopa levodopa condition, okay, dopamine is not going to be available. Okay, so there is going to be not formation of your norepinephrine and epinephrine, which is catecholamines. So you have decreased formation of catecholamines in your periphery. Okay, so the next thing is dopamine can also go and bind to your peripheral D1 receptors, which causes vasodilation. Okay, so the third thing is sometimes the drug can work, sometimes the drug cannot work. Okay, so that's called as your varying off fluctuations. Okay, that's what I said as an on and off. So sometimes it works, sometimes it doesn't work. The period between this mobility, immobility between you're taking levodopa, carbidopa is what is your mainly the levodopa is what is your on and off fluctuations, which is decreased with your carbidopa adding on. Okay, so any doubts with the adverse effects till now?
No, ma'am.
Okay, okay. So we can go to entacapone, tolcapone. The COMT inhibitors is going to be the enter. So can you see guys see over here the COMT inhibitors, entacapone, tolcapone. Okay, so we just have to remember what is the adverse effects of them because the mechanism of action is as simple as you are basically inhibiting your COMT. So therefore the L-dopa doesn't become 3-O-methyl dopa in the periphery by entacapone or tolcapone and in the centrally by the tolcapone. Okay, so now the adverse effects is going to be the same GI effects, same hallucinations, same delusions. Why? Because dopamine adverse effects. Okay, but if I have to be specifically saying something, I'm going to be worried about the tolcapone, which is usually known to cause your hepatotoxicity. But apart from that, nothing specific. Okay, apart from that, nothing specific. So next is monoamine oxidase B inhibitor selegiline and rasagiline. Okay, so selegiline and rasagiline, as I said, MAOB inhibitors, okay? B, okay? MAOB inhibitors, okay? So this is also going to have GI adverse effects. This is also going to have hallucinations because of the increased dopamine. But because it's an MAOB inhibitor, we have to be very careful giving along with any other serotonin, okay? Because we do not want a serotonin syndrome. We do not want another serotonin syndrome. So be careful with SSRI, with your SNRI, tricyclic antidepressants, with your triptans, with your tramadol, ondansetron, MDMA. I can keep going. There are so many drugs which basically have serotonin in them. Okay, so that means that when you're giving these selegiline and rasagiline, be careful. SSRI, SNRI, tricyclic antidepressant is the most common. Tramadol, ondansetron, triptans, MDMA, linezolid, okay, your cough syrup, dextromethorphan. Okay, so all these things, of course, you will be having a list on your own when you're studying for exams. It should be there in the books. Okay, it's there in the books, but you have to remember that one serotonin should not be given with along with another serotonin. That's the whole concept over here. And it could be even food. Okay, don't eat cheese, don't eat wine, don't take beer. Okay, don't take thiamine. Okay, because serotonin syndrome is very likely to happen. Okay, so usually you have to remember that thiamine is a substance that is present in all these beer and cheese and wine and foods. which can basically cause like a hypertensive crisis. So that's why you should be very careful. So the next drug is about amantadine, which is initially used for influenza, but right now used for your Parkinson's as well. They basically increase the release of dope. So it's also antagonizing your NMDA and methyl D-aspartate receptors. So that means it's preventing your glutamate signaling. Okay, so that means the glutamate signaling in the basal ganglia is prevented. So people who take amantadine, they expect to have a less of bradykinesia. Okay, they have a less of bradykinesia. That's what is the whole. So amantadine is known for certain side effects. One is libido reticularis, ataxia. What is libido reticularis? Lace-like discoloration. So next is ataxia, and next is going to be peripheral edema. So amantadine initially we used for influenza, but with time, okay, because what happens is we are using it for a very long time. Of course, it decreases your bradykinesia. You can also develop your libido reticularis, your ataxia, and your peripheral edema. So the next is the drugs that is mimicking your dope. Mimics of dope is Prami, Ropi, and Bromo. Of course, we don't use this because it's an ergot. We are again thinking about this because of its adverse effects. Okay. So the reason is the adverse effects, the impulse control disorder, like the gambling and the addictive behaviors, the eating disorders, the online gaming, all that is worrisome. Okay, so this is all because it is mediated by D3 receptor. The Prami causes all of this more than the ropinol. Okay, so sometimes you should know that this causes sleep attacks. It's not drowsiness, it's not sedation, it's sleep attack. You just start sleeping suddenly without any what is that, sleepiness or fatigue, or you knowing that you're going to get the sleep, you just start studying. So because in a 65 years old patient, okay, if they have Parkinson's and if you're giving these drugs, you should know they have these sleep attacks. So the sleepiness is really, really, really important. These dope and postural hypertension, hallucinations, and your edema and your nausea, all these are side effects of your dope. You guys would have understood by now. So the especially side effects is sleepiness and impulse control disorder when you give your Prami and Ropi. Okay. So now the bromocriptine is a toxicity. So it basically causes psychosis. It can cause pulmonary fibrosis. It can cause Raynaud's phenomenon, meaning your vasospasm. So all of these things are very, very important. Okay. So now we have done the Parkinson's drug. We'll just go for the tremor drugs. The one that's decreasing your bradykinesia is going to be your amantadine. The one that's decreasing your tremor rather than your bradykinesia is going to be anticholinergics, benztropine, and trihexyphenidyl. Okay, so it's because it's going to be M1 antagonist. Okay, so patients who are having tremors, you can put them on this. The only thing is that antimuscarinics and all patients, the adverse effects is something that you have to keep in mind because they have urinary retention with antimuscarinics. You have constipation with antimuscarinics as adverse effect, dry mouth with antimuscarinic, impaired sweating with your antimuscarinic. Okay, so all these blurry vision. Okay, so that's why we don't usually go for this unless and until it's like the patient of Parkinson's has only tremor and nothing else. So it's like it can also cause confusion, it can also cause memory impairment. So these kind of things. Okay, so if you keep doing like case scenarios, it will be easier for you guys to remember. But at the end of the day, what I want you guys to know is in an elderly patient, think twice before you're giving antimuscarinic and the dosage because we don't want the toxicity. Like we don't want the dry mouth, we don't want the impaired sweating, we don't want the constipation, we don't want the blurry vision, the confusion, the memory impairment, and the urinary retention. Okay, that's about the antimuscarinic side effects. So Parkinson's drugs is that's it. Any doubts still here?